We are live.
This meeting is being recorded.
I think we can start. Good evening, everyone, and welcome to the fourth webinar in our Salome Range Ask an Expert series. Tonight, we're discussing PCOS, or polycystic ovary syndrome, with specialist obstetrician gynecologist Dr. Lusanda Shimange-Matsose. I'm very proud. I managed to say OBGY without biting my tongue. I did it. I did it.
Well done.
Thanks, Dr. Lusanda. I am your host, Boitumelo Sebambo. Dr. Lusanda, thank you and welcome for joining, and welcome and thank you for joining us.
Thank you for inviting me. I'm quite excited about today.
I am. This topic, we've received a couple of questions, so I think we'll be occupied for a while. But before we start, I think let's do some housekeeping. As I said, we received a couple of questions. So we'll go through the questions that we received. But to everybody else who wants some clarity or has extra questions, please post your questions on the Q&A board. Your video and mic have been muted, but you can definitely ask questions. If there's something that you've missed, as I said, ask, or in a week, you can go to our website, www.salome_range.co.za. We will post this webinar, and we've posted the last 3 webinars, so you can always just go back and find out more information. Otherwise, you can find us, which is Team Salome, or Dr. Lusanda on our social media pages, and you can actually just tap into that bit of knowledge on there. Dr. Lusanda, let us start.
Yes.
Tonight we're discussing PCOS. I think the most obvious place to start is, what is PCOS?
Yeah, okay. So now, PCOS, polycystic ovarian syndrome, PCOS, they all mean the same thing. It's an endocrine disorder, which is the most common in reproductive women. And it has different sequelae, such as metabolic sequelae, reproductive sequelae, and so forth. But ultimately, it's an endocrine disorder.
What is a sequelae, Dr. Lusanda?
Sorry. So basically, that's a good question. Thank you for that question, Boitumelo. Very good question. Okay. So basically, primarily, it has endocrine disruptions, if I can put it that way. And as a result of that, you can get reproductive issues, such as infertility issues, right? Metabolic issues, such as diabetes and so forth. So basically, it's not just PCOS on its own, it's something that can potentially lead to something else if not managed correctly.
Okay.
Did I answer? Did I get that one? Did I knock it out?
You did. You got you got that one. I asked that for myself and on behalf of everybody else. I think that leads us then to one of the popular questions that we got is, what are the symptoms of PCOS? I think there's various, and most people are saying, I've got one. Does that mean I've got everything else? So maybe let's start with, what are the common symptoms of PCOS?
Yeah, so when we look at it, right, and this really will just take us to the diagnosis, but it's really, women complain about abnormal menstruation. So when I say abnormal menstruation, is that sometimes they have periods where they don't menstruate, some months they go by, they don't menstruate, and then they menstruate, and they can't really, the cycle is just very irregular. They can't pinpoint when they're going to menstruate, and the app that everyone has is just going crazy, because now you're making the app work extra hard in terms of determining your cycle. So that's really a big one that really patients present with. Then the other one, which you won't really present with this, but it will be something, and unless you know it could potentially be a problem, you won't really know it's PCOS, and that's what we call hirsutism. So what is hirsutism is the next question you're going to ask. So that's basically abnormal terminal hair growth in a male distribution pattern. What does that mean? You get your beard, you get your mustache, you get hair between your chest, on your back, or you get male pattern baldness or alopecia. So that's basically hirsutism, and that's signs and symptoms of hyperandrogenism. So you've got like a significant or an increased amount of male hormones, so specifically testosterone. And then the other thing is just that acne that patients get, you know, specifically around this area. And then on the back, we call it back knee. So that's what patients will have, but they may not necessarily link it to PCOS. And sometimes, and we really just elicit that when we see the patient. So you may be coming for, oh, I've got an irregular menstrual cycle. And then just by a patient walking in, there's certain, you know, we always say you make your diagnosis as a patient walks in, and then you confirm it just by talking to the patient and obviously asking them questions. And then you're like, okay, this could be, I'm not so sure, but could be, you know. So but the big one is irregular cycles. No woman of reproductive age must ever be happy about missing her period. And that's going to be my take-home message right at the end.
Boy, are we happy. It's just, you know, especially when you're younger.
No.
Especially when you're younger. When you're younger, you get so happy, you continue with your life. And then at some point, you become friends with that app that everybody's using. And the app wakes up before you do. And it's like,
what is happening? 5 days late, 10 days late. You must freak out. Unless you're my age, you must freak out. I'm happy to play hide and seek with my period.
No, I think it's just one of those things where maybe it's upbringing and culture. We're not brought up to be friends with our periods, for lack of a better term. And I think also because some people have got really bad pains. So when you go through a period and you're just not experiencing any of that, you have this, whew, I can continue, I can run, I can wear that pair of pants, do whatever. And then it's quite late to then come back and realize, actually, I'm on week 8.
It's a problem.
And this thing only comes in 2-3 months, as opposed to the 8-day cycle. So that, and then the hair thing.
Agree.
Then the hair
thing. Talk to me.
The hair thing, you never taught about it. You know, I think it's one of those things where, particularly in women of color, you lose hair, somebody's going to say traction, or somebody's going to say chemicals on your hair, and then you know, it's just continue. You know, as you're speaking, I'm like, the number of times I've seen a friend or somebody, I'm like, the acne combination, you know, hairs on the chin, and you're like, oh, okay, is that what was going on?
And the thing is, you know what, and I suppose because I see it all the time, and obviously I've just got, you know, I mean, that's what I do. Do you know what I mean? And you know, we just kind of like normalize certain things in society, because we've all seen someone who's got the beard or who's got that bad skin, you know, and we're like, oh, you know what, okay, fine, they've just got acne, and then you go to your dermatologist and so forth, and that's the whole thing is, and sometimes people are just too shy to ask, you know. People are just too shy to ask. And I mean, I had a patient the other day, and it was one of my juniors, and I was like, oh, okay, no, this patient is probably, and incidentally, it was actually a PCOS patient. And I say to her, but you can see it, like she's got alopecia, you know, like that hair loss, you can see it. I'm like, yes, we can argue that it's traction alopecia, but then it's kind of like, it's quite well defined, you know, it's very obvious, you know. And I'm not saying everyone now who's got alopecia has PCOS. No, I'm not saying that. I'm just saying these are just certain things that as a woman of reproductive age, just be aware of them, you know, that it could possibly be, and just rather consult and know that it's not, or know that it is, than just have no idea.
Leave it be. Yeah. One of the other things you also mentioned, you know, when we're talking about endocrinology, was the relationship with diabetes. You want to get more into that?
So basically what happens, and PCOS, there's a lot of overlap in terms of PCOS with other disease processes. But one of the things is that you get different types, but one of the major types is where women are obese, right? And then in terms of the metabolic sequelae of it, is that you get your high cholesterol, you get your insulin resistance, and your high blood pressure. And if all that is not managed, eventually it will lead to a diabetic state, right? So those are also specific things that we guard against when we have patients who've got PCOS. We normally will test for diabetes. We will test for cholesterol if we can see that, specifically if it's an obese patient, because you also get PCOS patients who are small patients. So it's just a different type of PCOS.
Okay. We're getting a question here, which is not actually any of the symptoms you've spoken about. Somebody's speaking about, does PCOS interfere with oral health? Very interesting.
It's a very interesting, I must admit, out of all the PCOS seminars I've done, no one's really asked that. And nothing to my knowledge, I must admit, I have never come across PCOS and oral health, no.
Okay.
Yeah.
Yeah, I'd never seen it before, so I think this is what just stood out. So is there a cure for PCOS?
Is there a cure for PCOS? PCOS, no. It's a syndrome, it's there, it can be managed, but there's no cure. Does that make sense? No, you can't come and see me, you've got PCOS, and then I treat you and then boom, PCOS gone. No, I can manage your PCOS, and I can manage your PCOS according to your symptoms, and I can manage your PCOS to prevent that sequelae that I was speaking about, metabolic issues, your risks of getting endometrial cancer, but I cannot treat it away. So no. Yeah.
Seeing as we're talking about treatment, my next question is in two parts, and we'll break it up initially.
Yeah.
How do we treat PCOS for women who are trying to conceive? And then how do we treat, let's start there. Let's start with, how do we treat PCOS for women who are trying to conceive?
Okay. And I really like that question because a lot of women who've got, or let's just say women in general, and I know I'm kind of like going off track a bit because we're speaking about putting off pregnancy and so forth, and the other thing is that PCOS and amongst other disease processes is that if a patient comes and is struggling to fall pregnant and you identify why they're falling pregnant, why they're struggling to fall pregnant, in other words, PCOS, then those are patients that we investigate straight away. So the first thing to answer your question is lifestyle modification. Guys, anything in medicine is lifestyle modification. Okay, if your doctor does not say lifestyle modification, you must worry. Okay, so if you're obese, you must lose weight. And I say that in the nicest of all ways, because I know patients hate it when they go to a doctor and they're like, yeah, she just told me to lose weight. There is so much power in that because we've got studies. There is data that when you're a PCOS patient who is obese, just 5 to 10% of your loss of your current body weight, you can return to spontaneous ovulation. What does that mean? Is that if you're ovulating, you're producing an egg that can be fertilized, which means you can actually fall pregnant naturally, provided everything else is in place. So in the event that you are not ovulating, then there's something that we do, ovulation induction. So that's basically now you go to a fertility specialist and we assist you in creating that egg that can get fertilized. And then there's different ways of doing that depending on what we find after we investigate. So your options with the patient with PCOS is that you need to consult if you are struggling to fall pregnant. Certain investigations will be done, and we'll be able to determine whether, depending on your age as well, that's a very big thing, we'll be able to determine whether you should go the natural route or you should go the assisted route. And if you are of a higher BMI, 5 to 10% loss of your current body weight, you can return to spontaneous fertilization.
Yeah. Look, I think, Doc, in the age of body positivity, culture positivity, yes. And there's a lot of information around, doctors are gaslighting people. The BMI conversation is a very difficult conversation to have.
Yeah.
And particularly if somebody comes in, those who are in relationships comes in without a spouse. If my spouse likes me this weight, look, I'm not a doctor, but I think it must be a really difficult conversation to have with people.
So I think it also depends. Like, I don't find it difficult at all. Yeah. I don't, and okay, obviously I can't tell you who my patients are and stuff, but I really don't, because I just look at the bigger picture. Do you know what I mean? I look at the bigger picture, and and I believe there's power in education. There is power in education. And at the end of the day, by the time you leave, you either take it or you don't. But I need to give you that information and you decide what to do with it. Do you understand? And I know, because I was actually having a conversation the other day with a patient, and I say to her, and these were my exact words, and I said, I mean this in the most nicest of all ways. Like, there's no other way I can actually say this. But when I look at your BMI, it actually falls in the obese category. And this is also part of the reason why you're experiencing what you're experiencing. So it may be difficult, but can we try and lose weight? Right. And I mentioned all the risk factors. Especially if you're a young patient, you're 25, and then now you're going to have diabetes, you're going to have high cholesterol, you're going to have hypertension, and then later on, you've got an increased chance of getting endometrial cancer, and then you've got sleep apnea, and you've got cardiovascular disease. I can go on and on and on. So I think there's a difference between, and we're not gaslighting anyone, there's a difference between health, because you can still be a bigger patient, but you are healthy and you don't have those things, And I think, it's like a patient who's underweight, who's not having her period, I'll say, listen, you are actually really underweight, and let's put you on a certain diet so that to at least increase your body mass, So it's really, it is a difficult conversation, but I feel as clinicians, we know how to get around it. We know how to get around it. Maybe it's more difficult for the patient to hear than for us to say.
That probably, I think that's usually where it goes. One of the things that we've spoken about in the series is also finding female doctors. Most people are saying that is also helping their process, and I think that's because for the long time, gynaes were not women, or we're not black if you're black, white if you're white, or colored if you're colored. So people who just did not have the relativity of their lived experience, and I think now there's an effort amongst patients to find a doctor who looks and sounds like them.
Yeah, that's very true. I agree.
So the second part of that question is then, is the treatment the same, or is it different treatment for women who are not trying to fall pregnant?
So different treatment, but still lifestyle modification. I will not leave that one, right? Still lifestyle modification. But if you're not trying to fall pregnant, it's also about what's your presenting complaint, right? So if your presenting complaint is you're just actually worried that you don't get your period every month, then hormones, we use hormones a lot in gynecology. I'm so sorry for all the listeners out there. And I'm really saying this because as patients walk into the consulting room, doc, you can do anything, just don't give me hormones. you know. So, and unfortunately, it is what it is, guys. Our bodies run with hormones and stuff, and sometimes we need external hormones in order to balance those. So there's hormones that we can give out, right? And then there's insulin sensitizers that you can give, so the metformins of this world. And then in terms of your, if you say now you are trying, it's the hair, the facial hair and the acne, that's the problem, then we treat those accordingly. And we've actually got hormones that would address those specific things. So the reason why I'm saying it is different, because the hormones that we would give you would be an oral contraceptive pill. Whereas if you're trying to fall pregnant, we would not put you on that because it's just counterproductive. Yeah.
Thanks for specifying hormones, because I'm seeing a lot of questions on the Q&A board where people are actually asking about contraceptives. It's either oral or UID. So I think that answers the question, because I think people are asking, would it help if they were on in terms of that. Then I don't know if you're able to answer this, but the question says, what are the chances of falling pregnant if I have PCOS?
Good chances, very good chances, provided that is the only thing. Why am I saying that? Because when we look at fertility per se, how does a patient fall pregnant? You need a uterus, you need your fallopian tube, which is open, you need your eggs, and then obviously you need sperm, right? So if you've got your tubes that are open, you've got a uterus that looks beautiful, and the only thing that we're dealing with is PCOS, right? Then, like I say, then we can look at natural ways, we can look at assisted ways, right? Does that make sense? But if you've got blocked tubes, let's just say you've got blocked tubes, then obviously the natural way is not going to work. Then you go the assisted way. If you've got a uterus and let's just say it's got fibroids in it, then we can remove the fibroids and then lifestyle modification, all that stuff, and then you can fall pregnant. So PCOS does not mean I can't fall pregnant. PCOS means if I want to fall pregnant, I must be with a gynae who is well averse to managing patients with PCOS and fertility issues. Yeah.
As a lead on from that is, now I've fallen pregnant. I used to have, or I do have PCOS, because we said we can't cure it. Are there any complications during the pregnancy that are as a result of the PCOS?
So if, like I said in the beginning, that those patients at increased risk of diabetes, high blood pressure, and so forth, so those things may arise in pregnancy compared to the general population without PCOS. Diabetes is a big one, but that's a nice thing. Well, let me not say the nice thing, but that's the nice thing, for lack of a better word, is that once you know that you're pregnant with PCOS, right, those are the things that we look out for. And those are the things that we'll tell the patient from the first consult, kind of like, okay, fine, now you are pregnant. These are the things we're going to monitor for. So all the other things that would normally do the normal a patient who's pregnant, where we check the urine, we check the blood pressure, and we'll do a diabetes test during pregnancy to make sure that you don't develop diabetes. So all those things can be managed. So yes, they may happen, or you may just have a pregnancy that is very easy, you know, but we will have a mental note of that this person could develop 1, 2, 3.
I'm seeing a couple of questions on symptoms that you didn't list. So yes, similar to the oral health one. So we'll go through them. The one says, does PMS affect my sex drive? I mean, no, not PMS, PCOS. Yeah.
Okay, so the reason I didn't list that, because it's not the outstanding symptom, because it's not classified as a symptom or sign of PCOS, right? I won't lie, I generally will ask patients about the sexual life, if there's any sexual dysfunction or anything like that. but I will not link it to PCOS. Does that make sense? It's literally like bottom of the list. And even if I mention it, but with that being said, there are some studies that, but these are very small studies, it's not robust data or anything, that say that patients with PCOS, they do have sexual dysfunction. Now, sexual dysfunction is a very big term because it's actually listed in the DSM-5, which is a psychiatric standard for listing psychiatric disease processes. But the whole link with sex and PCOS is more about, when you look at a sexual response cycle, arousal, desire, arousal, what do you call it? Lubrication, and orgasm, right? So in any of those, they could be affected from a body image point of view. So now, let's just say, for instance, and I say this the most respectful way, only because of societal standards that have been set there, is that now you are obese, right? You're struggling to lose weight. You've got the acne, and then you've got the beard. And as a woman, you may not necessarily feel attractive, right? So your desire to have sex may not necessarily be there just from a cosmetic point of view, which would happen to any other patient, and any other woman who does not necessarily feel attractive. They're not exactly going to be jumping on their partner if they don't feel attractive within themselves. And then there's the whole issue of fertility as well. So now you're struggling to fall pregnant, right? And and that may cause marital problems. So that could be a break in the sexual relationship that you have with your partner. So it's not an independent cause of sexual, of sex and sexual desire and so forth. It's more about everything else around PCOS that results in the sexual dysfunction.
I think it's so important, and we used to not talk about it. Now we are, in terms of the mental health impact of reproductive issues, particularly fertility. And now that we're realizing that reproductive health challenges and symptoms also relate to how one looks. And I think it's so important that we get into that, because I think we're so used to dealing with, what's between the neck and the pelvis, and nobody actually ever considers that if I've lost my hair, how does that impact me? And for me, it's just a favorite topic because I've lost my hair, and just having to participate in life, from having an afro that big to just like, okay, where is it now?
It's gone. Yeah. Yeah. And it's a huge thing, Boitumelo. It's a huge thing. And I think, it's specifically, and the thing is, this really just goes across all age groups. We always speak about the young girl child, but it's also like people my age, people your age, just everyone gets affected by that. And it's really standards that have been set. And I just believe it's really an individual thing in terms, because I'll ask the question, how does this affect your relationship?
Yeah.
Do you know what I mean? I'll ask that question, and it's a hard question to ask. Someone said to me, why do your patients always end up crying? Well, not all my patients. Why do your patients cry? And I'm like, because we ask the hard questions that people are generally, they don't necessarily want to address them, And when you are sitting there with your gynae or with your doctor, and you understand the disease process, you can ask those questions and just delve deeper. And there is a huge mental component to this disease process. And it's not just, and I always say, biopsychosocial model. That's how we address things. Yeah. Biopsychosocial model, you have to address each one.
I'm writing that down. I've got many nuggets, and that's one of the ones that I'm writing down. So on the topic of mental health, somebody's asking something which, now that I'm on the fourth one of these, I think it's more of PMS symptom, but I'll ask it. She says, How do I handle depression, anxiety, mood swings caused by PCOS, as well as severe PMS?
Yeah, no, that person, whew, that's a lot. That's a lot. So with the, okay, let me just answer it in two parts. With the anxiety, depression, because of PCOS, that you can basically manage that because, is the anxiety and depression caused by the fact that I'm not falling pregnant? Is the anxiety and depression caused by the fact that I've got this acne that I just can't get rid of, or I've got this beard, I shave before I sleep and I must still shave when I wake up, or is it caused by the fact that I'm literally trying to lose this weight? I run the comrades, I don't eat anything, but nothing is happening. So we have to address what's actually causing it. So actually within the DSM-5, they always talk about the mental illness due to a general medical disorder or general medical condition, right? So before they actually treat that, they always say treat the medical condition and see if the anxiety and the depression improves. Okay, so that's the part about PCOS and anxiety and depression. In terms of PMS, so did you say PMS? So the mood swings?
Yeah.
Okay, so with the mood swings, and this is something I really learned a little bit later in my career, is that, if you need to learn your body, and the cycle goes in different moons and different cycles, right? And at that specific time, you need to be aware of what is going to happen, and I always say the mind is such a powerful thing, because and this now goes against I can easily just put you on hormones and say, okay, fine, this will deal with the mood swings, and then you have an adverse event to the hormones and your mood swings get worse. So it's just really being aware of your cycle as a woman, and know that during this time, this is what's going to happen. You're going to get the mood swings. And how do you control those mood swings? I know it sounds so very airy-fairy, but it's more of a cognitive, behavioral way to deal with that. I don't know if that makes sense to you.
To me, it does. I hope
and
to the people that asked that question, it does.
You can have a follow-up question. If it doesn't, I'll
keep
it.
looking if there's a,
Okay.
there's a follow-up question. There are a couple of follow-up questions on weight loss. I'll get to those. But I think, let me see, there was an interesting one that had to do with what we're discussing now. So I just wanted to continue with that. Okay, so I wanted to take us back to the very first question, which was, what is PCOS? And that's because I'm seeing a couple of questions on...
They're not getting it.
Not that people are not getting it, but there are questions that I think relate to ovaries and ovarian function.
Okay.
Yeah. So I think maybe let's start with ovarian function. What is supposed to happen, and then I'll get into those questions.
Man, I wish I had like my cards so I can just show them to everyone that I show to my patients when I talk to them. So basically, and maybe I should have just gone more into that answer instead of just saying it's an endocrine disease with metabolic sequelae. So how we actually diagnose it, so we use a certain criteria where we look at, first of all, does the patient have irregular menstrual cycles? I spoke about that, and I'll delve into that deeper. And then I spoke about the hyperandrogenism. So that's the hirsutism, the facial hair, the acne, and so forth. Or are there high levels of testosterone in the blood, right? The other one, now the ovaries, the ultrasound, the PCOS patients have what we call polycystic ovarian morphology. So what happens with PCOS is that, okay, what happens in a normal menstrual cycle is that your eggs go through specific growth phases, right? And then round about day 14, then you get the big follicle. And we call that the dominant follicle that's the one that will get fertilized if you have sex at the right time, or it ruptures. That's when you get that ovulation pain that people speak about. So with polycystic ovarian syndrome, you don't actually, the follicles don't go through that growth. So you just have all these little immature, small follicles in your ovary that are doing nothing. They're just there, right? And that is actually the issue with this. That's what we call polycystic ovaries. So it's just these small follicles, and that's one of the reasons why patients will struggle to fall pregnant, because they don't form that big follicle that should mature, the one that gets fertilized. So imagine like, and I always use the worst analogies, but they make sense. Imagine you stay in grade 2 forever, right?
No,
do you understand what I'm saying?
Yeah.
Up until someone comes to you and says no, and then you start getting the tutoring and so forth, and then you start progressing.
Yeah.
That's basically what happens in a PCOS ovary. You stay in that follicle stays in grade 2 forever up until we start treating it.
Okay. No,
Does that make sense?
That makes sense. Okay. I'm trying to figure out if I can run with your analogy to ask the next question, but I don't think I can.
Run with it. You can try.
Because the question really is around having understood, I guess, what's happening with the follicles, or I'll call it a follicular underdevelopment. Does that mean my eggs are getting saved? And I think maybe it's going to somebody who's trying to fall pregnant, trying to find out if they've got a higher egg reserve because they've got PCOS. I'm making that assumption that probably is their understanding.
No, that's actually a very good question. It's a very good question, because there's a blood test that we actually do in the fertility world. It's called your anti-Müllerian hormone, or AMH. So those patients with PCOS generally have a very high AMH, right? Yeah. So it's not to say with each cycle that a patient has, your ovarian reserve does go down, but PCOS patients will have a higher ovarian reserve. It's just the function of those follicles is not the same as someone who is without PCOS. So the function is completely different. The PCOS patients have immature eggs, follicles. Does that make sense?
Yes.
The one without PCOS has immature follicles that can grow out of the immaturity to become mature.
Okay.
Yeah.
The next question, also on ovarian function, I don't understand, but maybe Doc, you will, because I don't know medical procedures, but the person is asking, is ovarian drilling a must in patients with PCOS?
It's not a must. Must is a very big word, because must means you have PCOS, you must go and get ovarian drilling. No, it's not a must, but it is a procedure that is done in polycystic ovarian syndrome should the situation warrant it. It's one of the management options.
For the rest of us, what is ovarian drilling?
So ovarian drilling is a procedure that's done in theater, and it's done laparoscopically, so keyhole surgery where we make holes, but you can also do it in open surgery, but ideally you should do it laparoscopically where we make holes and we just go in with the camera, and basically you just make little holes in the ovaries, right? And that is that it can assist with ovulation. Basically that's it. So it's just basically burning little holes in your ovaries.
That's interesting.
Yeah,
that is very interesting. So now I'm going to take us back to treatment. There's people who are asking natural options versus chemical options. What should I be doing for PCOS?
What you should be doing is consulting with your doctor who can look at the overall picture, and based on what they find, then they can design some sort of treatment plan for you. Me personally, I do look at the patient and I play with both. I play with both depending on what we are trying to achieve, right? So in other words, I could put a patient on allopathic medicine and natural medicine to achieve a common goal.
Okay.
So it really just depends, what does the patient want? Clinically, how does the patient examine? Right? Are we dealing with an obese patient with PCOS? Are we dealing with a small patient with PCOS? Because even the natural stuff that is out there, you know, when we look at the data and the literature, it's for a specific subset. It's not necessarily one size fits all. So for me, I just highly recommend that any treatments that a patient takes, no one must self-medicate, rather have it in consultation with your gynae.
Okay. I mean, I'll ask the next one, but you know, you've answered that, and I think you're still going to direct the person to the gynae. They're saying, can we talk inositol? Does the doctor recommend it?
Yes, we can definitely talk about it. How can I not talk about it? How can I not? No, so basically with that, like I spoke about a specific subset of patients, and those are really the patients with hyperinsulinemia, where we see a lot of improvement with regards to those patients, just basically from an insulin point of view, from an egg quality, and as a result, from an egg quality point of view in terms of the patients falling pregnant. So there is definitely room for those. But like I said, like you said, I'm still going to direct them, you know, and I believe each method just really has its benefits. I'll never outrightly say no to something. Each one has its own benefit, and that's why it's so great. Like when you actually see and you take a full history, full examination and investigations, and based on what you get, you can actually recommend whatever treatment you can prescribe, a certain type of treatment for that specific patient. Where it becomes a bit of a challenge is when a patient just wants only natural stuff. And with that, and the reason why it becomes a bit difficult is that then what if that does not work?
Yeah.
Do you understand? So my thing is that I always say to patients, you need to just be open-minded about, we're not just going to necessarily just be throwing all this allopathic stuff at you. Do you know what I mean? But you just need to be open-minded in terms of the treatment process, because you'll basically be hampering your own treatment.
Yeah. I mean, some of the questions here, somebody's, you know, is saying, I've lost weight, but I still have the cravings. Other questions are, how do I control cravings? Others are, how do I lose weight? What's the supplement? If you can tell us how to control cravings. I mean, just before this webinar, I was good friends with chocolate, but people just want to know, how do they control cravings? With both.
I'm laughing. No, I'm laughing because yesterday I took out a slab of chocolate without any guilt, and I'm eating it, and my husband's like, "Are you going to eat all that?" And I'm like, "Do you want some?"
Are you
Why
asking
funny questions? You know, what are you actually asking me? But look, okay, let's just on the weight. Sorry, the first one was weight loss, right? I've lost weight, but I still have cravings.
Yes.
So for me, the whole weight loss journey and what you do for weight loss, it needs to be something that you can maintain, right? It needs to be part of your everyday life. So in other words, yes, I don't eat a slab of chocolate every night, but I'm not taking it out of my diet. Does that make sense? I'm just limiting how much I eat. I mean, like, yeah, I mean, yes. I mean, I'm not surprised I got asked, are you going to eat the whole slab? But so I think my advice more than anything, because if you completely let go of something and your body just does not adjust to it, you are going to continue to crave it. Simple thing like, let's just say coffee, you know, if you drink 10 cups of coffees a day and then you're going to just stop drinking coffee, I'm sure you are going to crave coffee, right? So for me, the cravings thing is when you do an adjustment in terms of your diet, don't be too drastic from the beginning. Make allowances so that you don't have those cravings, right? That's the first one. And then the second one, so it was weight loss and I'm
the second
struggling.
one, no. It's still in the weight loss thing. Somebody was saying, can I just take supplements to lose the weight? And it's related to somebody else who's saying that despite losing weight, they actually just
crave.
can't move. No. So there's another one where somebody's saying, I actually can't make the effort to exercise, or I can't move, I can't exercise. So okay. I think it's what else is out there?
Yeah. So yes, there is specific medicine that you can take to lose weight. The problem with those, ultimately, they just really act as appetite suppressants. And then when you stop taking them, you get your appetite back and then you put on the weight. So it's just about really developing a lifestyle that you can keep up with. In terms of weight loss, I always say to patients with PCOS who are struggling is to rather see a nutritionist or a dietitian who can assist you with a lifestyle change tailored specifically for PCOS patients. So that's the one thing. And then exercise, I always say, you don't need to go and do boot camp. Do you know what I mean? You don't need to go and run marathons. Exercise sometimes is simple. Don't take the lift, take the stairs. Because there are people who just struggle to use the stairs. So first take just one floor. And then, I mean, that's what I do sometimes at the hospital, because I don't actually exercise. So I'll take a flight of stairs and then land on the floor and then go to the next staircase, so that at least I get a bit of a breather in between, you know, to avoid using the lift. So sometimes it's just little changes that can actually assist in the weight loss. If sugar is your thing, rather than putting 4 spoons of sugar in your coffee or tea, cut it down to 2. Eventually you'll be on no sugar and you won't crave sugar. So it's just, you know, it's how do you eat an elephant one bite at a time? And that's what I say to patients. Don't put that much pressure on yourself. When I see my patients and let's just say they've got a high BMI, I say, okay, fine. So this is your BMI. I'm going to see you. Your next visit is in 6 months' time. Let's try and maybe 1 or 2 kgs. Do you understand? So that's not really putting a lot of pressure. I'm not saying 10 kgs from the onset. And I think what happens with patients is that they just want everything to drop off overnight, and we don't expect that.
Look, I think one can understand, particularly for patients that are trying to fall pregnant, you know, why there could be time anxiety related to that 6 months versus 4 weeks type thing. One can actually understand how patients can get anxious.
But that time anxiety, if you're trying to fall pregnant, remember, it's also for the patients without PCOS.
That's true. Yeah.
Do you understand? It's not exclusive to patients with PCOS. It's literally any woman who has decided, I want to fall pregnant, already time is a factor.
Yeah.
You know, yeah.
We've got a little bit of time left, so I'll go back to the PCOS specific questions. Back again to ovarian function. Somebody says, hi doc, does PCOS increase chances of birth defects? I'm asking because I heard you speak of compromised egg quality. Yeah. No,
it doesn't. It doesn't. It's the same as the general population. When I say egg quality, you know, when an egg gets fertilized, there's certain factors that should be there, right? So in other words, if an egg is not good, it won't get fertilized. If it does get fertilized, maybe a patient can end up with a miscarriage. Does that make sense? So it's not necessarily you carry to term and then you'll have a baby with birth defects. No, not related.
Okay. In actual fact, earlier, I've just lost it. But there was somebody who was, oh, there we go. I found it now that you brought up miscarriages. Somebody saying, I've had 2 miscarriages. How do I prevent these miscarriages? And I think maybe she's trying to find out if they're a result of the PCOS.
Is there someone with PCOS or they've just had 2 miscarriages?
I think she might have. She's not saying, she's just saying currently not seeing my period as well for 3 months. So I can maybe make that assumption.
Okay. So the first thing, currently not seeing my period for 3 months, I'm like, can we do a pregnancy test first, girl? Let's start there. Let's
I'm crossing fingers for her. I'm crossing fingers for her that
you know what I mean. You know, with the whole miscarriage thing, and there's that whole notion of, and I say this to everyone. Look, I say a lot of things to everyone. I'm sure you figured that out by now. But there's the whole, you know, I'll only go and see my gynae after the safe period.
Doc, she says she's done a pregnancy test.
Okay,
and I'm assuming it's a no because she's just
okay.
Done a pregnancy test. Yeah.
Okay, no, that's fine. So I'm back to sorry. I was saying that patients have this safe period thing going on, right? And I get it. It's a societal thing, but safe period does not work for us as health workers. We want to see you from the onset, especially if you've got a history of miscarriages. So by definition already, if she's had 2 miscarriages, we call that recurrent pregnancy loss. So she should actually go for preconception counseling so that we can do certain investigations to see if those could have been the possible causes of the miscarriages. And then if a cause is found before she falls pregnant, then at least we can attend to that. And then when she is pregnant, then we know this is a high-risk pregnancy. Certain measures have to be taken in order to maintain the pregnancy up to viability. So, yeah, did I answer the question?
I think you did, Doc. Because now we're running out of time, there's like more questions, but I think you did answer the question. If she's got a follow-up question, she'll ask.
Okay.
There's something that keeps popping up, which is bloating and indigestion. I think I missed that because it's being asked again. Are those symptoms of PCOS?
No, not necessarily. If you've got bloating and indigestion, so from an indigestion point of view, is that specifically if you are obese, right? That reflux that you get just generally as an obese because of the increased abdominal pressure, right? And in terms of bloating and stuff, you'd have to look for other causes. Are we dealing with IBS, irritable bowel syndrome or not? Or is it Crohn's? So there's other GI stuff that we'd have to look at, but not specifically pinpointed to PCOS.
Okay. Somebody said, would you suggest a full hysterectomy for a young woman who has no interest in having kids, who's tired of pain and extreme PCOS?
No, never, ever. If you're having pain as a young woman, unlikely to be PCOS, right? Then we have to look for another cause. But I would not recommend a hysterectomy in any woman of reproductive age unless you tell me you've got a cancer. So no, I most definitely will not. And actually, like, my heart goes out to that, whoever that posted that. And my next question is, have you seen a gynae? Has this pain been thoroughly investigated? And if not, that's the first thing you must do tomorrow, because it's going to, as soon as a woman starts speaking about a hysterectomy, specifically a young woman, not because she does not want to have kids, but because it's causing her distress, that's a huge problem. Then we're dealing with a bigger problem, and that needs to be addressed.
No, I hope she's heard you, Doc. I think from this series, the one thing that I've learned is we are not supposed to be in any form of pain.
100%.
Comfort, but really we're not supposed to be in any form of pain where you cannot move, where you cannot function, where you cannot walk. And I think we've been so socialized into high pain threshold, reproductive health equals pain.
100%.
I'm learning.
I mean, I always say to women, if you've got any form of pain that interferes with your quality of life, it's not normal. It is not normal at all.
I'm just going to give an instruction to the guys at Team Salome. Don't switch us off as yet. Don't switch us off. I know we said 9 o'clock, we've got 3 minutes, but somebody keeps asking about how to treat alopecia. And I think I've seen a couple of these questions. So I just want us to cover this alopecia question and one other question. Team Salome, don't switch us off, and then we'll wrap up.
Okay, so with alopecia, basically, I would suggest that a patient goes and sees a dermatologist, right? And then you get, and then with them, they're able to basically have different formulations in order to enhance hair growth. So that's the alopecia one. And then
the other one says, I have not seen my periods for 4 years. Would this be as a result of PCOS? I've been to 2 gynaes. They have not diagnosed me with PCOS, but hormonal imbalance. She's done HRT and still no sign of the period, and she wants to fall pregnant. She's just not sure what to do yet.
That's a very, is the result of PCOS? Unlikely, right? Because PCOS, you can get the period back. So that person needs to come and see the 3rd gynae. No, but jokes aside, no, there needs, there's different causes. I mean, I'd want more questions. How old is she? When did she first start having her menstruation? What was her menstruation like? Is she on any medication? Has she had any form of surgery? Does she have any medical illnesses? So that's a very big question. But to answer her, unlikely to be PCOS.
Okay. Doc, the questions keep coming in, but our time, this is, it's just so unfortunate.
We tried.
We tried. Our time was only for an hour. So to everybody who still has questions, we'll do 2 things. One is this webinar and all the others. So we've had a webinar on fertility, we've had a webinar on PMS, and we've had a webinar on menopause. Those are already up on the Salome website. This one will be up in a week. It is www.salome_range.co.za. You can also find Dr. Lusanda online it's at My First Gynae, right, Doc?
At My First Gynae, yeah.
At My First Gynae. Ask us any questions that you felt we didn't get to, and we'll try and respond to as many as possible. Because we are running out of time. Doc, any last words?
First of all, thank you for having me here, and I really hope I imparted some sort of knowledge to the audience. I'm very passionate about women's health. I'm very passionate about paying it forward in terms of the knowledge that I had the privilege to get, and I really want women to understand their bodies and to not be afraid to ask questions and to go and consult if you're not so sure. I know they say ignorance is bliss, but when it comes to health, when it comes to reproductive health, ignorance is not bliss, because it has such dire consequences, and we see it all the time. So for me, all those that are here and your friends that aren't here, please get them to go to the Salome website, and they must just watch these webinars. There's really a great deal of information that can benefit someone's sister, someone's mother, someone's friend, and so forth. And yeah, hit me up at my first gynae. I'll see. Look, I have moments where I go on. Sometimes I get social media shy. So, but I mean, like, go for it. But just pay it forward, guys. Just pay it forward. Whatever you picked up here, give it to the next person.
Thank you so much, Doc.
Thank you.
And to the team that is behind these webinars, thank you very much, Team Salome. Two things that I want to say to everybody is, anybody with a young daughter who's never been to a gynae, Dr. Lusanda is really, really, really passionate about that, and just easing young women into their first gynae visit. Some of the stuff that she's written is on the website around that, her articles, the blogs. So please just go read that. I think it's so important that at younger age, women just get comfortable with going to see a gynae. I think just in my own life, had I seen a gynae at age 15 versus mid-20s for the first time, so many things would have gone so much better. Doc, I think my takeaways is health versus healthy, lifestyle modification, and biopsychosocial model. Those are the things that I am taking away.
Yeah.
Again,
Thank you
all, and good night.